foot and ankle partner with Vanderbilt Bone and Joint. And sort of a nice time to kind of come and talk to you too, because we just opened a foot and ankle center actually today. So you may be familiar with Vanderbilt Bone and Joint or the old Franklin Bone and Joint. So just down the street on Bedford Way, corner Bedford Way and Royal Oak, there's a new office there that has two of the podiatrists from Cool Springs, Dr. Dieter and Dr. Trenner, are joining me and Dr. Durr. And they'll also have a nail tech there as well. So really any of your foot and ankle needs, we should be able to handle over there. So
part of the surgery center or part of the?
It's in a different location at the surgery center, but we have privileges there. Dr. Durr and I both operate there.
And did you say knee?
Foot? It'll just be foot and ankle for now, but we can see you for your knees too.
I thought, okay.
They got Dr. Thomas over here.
He won't turn you away. But I did a foot and ankle fellowship and do mostly foot and ankle as part of my practice, but we see a little bit of everything too. So I'll get started. I'm just going to talk about a few of the common things that happen with foot and ankle pain. You're welcome to stop and ask me questions. I'll be happy to answer any specifics you have. But sort of the most common things that we see in practice are, plantar fasciitis and then bunions and hallux rigidus, which is like a stiff big toe joint. You get some arthritis in that as well. And that's kind of what we'll start off with, and just stop me if you have any questions. Okay. So pain in the foot. So we'll start talking about plantar fasciitis and heel pain. So really the most common thing that we see in our clinic is plantar fasciitis, and you've probably talked to a few of your friends, they've had it. Basically the numbers are about 80% of people will have it at some point in their life, so just about everybody's going to experience it. The typical course for it is first thing when you wake up in the morning, you put your foot down on the ground, you have a very sharp pain underneath your heel, and as you go it may ease up a little bit, some people's don't. We looked into causes for this and haven't really had a great relationship. There is some thought that maybe the Achilles tendon is involved, that a tight Achilles can lead to a tight plantar fascia. And there's also some other things which we have to consider to make sure it's just plantar fascia. Sometimes you can actually get some irritation of nerves that run in that area, and I'll show you a picture in a little bit. And that can be another common cause. And those are probably the highlights. So common symptoms. That this is called startup pain. That pain when you first get out of a chair or first put your foot down on the ground, pain underneath your heel. That's classic for this. It usually is worse with prolonged activity. So if you run or something like that, the next day you feel it, or if you walk around a lot, you feel it the next day. You pay for it. But you can see here the plantar fascia. They used to make a big deal about these heel spurs, and people talk about those. Now, there is something to say that 15% of people just have those heel spurs and they don't necessarily hurt. But 50% of people with heel spurs will have the plantar fasciitis. They used to talk about taking the spur off during surgery, but that didn't really bear out. It didn't really have any difference in terms of doing that or not. So in terms of the clinical course, we don't really pay attention to it that much because it hasn't really shown to have a benefit. This is kind of a good lunchtime picture here. I'm sorry, but basically this is the bottom of the foot here. You can see this is the toes up here, and that's the heel. And the plantar fascia runs on it's the most. After you cut through the skin, you can see the skin here. There's the fat right underneath. That's the plantar fascia. It runs all along the bottom of the foot to the base of each of the toes. And so that's the course of it. It's almost the continuation of the Achilles tendon that comes around the heel. And then if you cut that away, you start to see some of the nerves. This is one of the nerves that kind of runs underneath that area. It's called Baxter's nerve, and that can sometimes be another cause for heel pain. So this is a little nicer lunchtime drawing of it. So you can see here, this is the Achilles tendon. The calf muscles start up here. The Achilles tendon runs down through here, attaches to the bottom half of the heel bone, and it's almost the continuation of that forms the plantar fascia. And sort of this area right here is where you get that pain in the morning. Sometimes you get this is Baxter's nerve, or the other name for it, but it can run in that area. Typically, we'll release that during surgery just to kind of make sure that that's not a contributing factor. So the great news about plantar fasciitis, though about 80% of people will have it at some point in life, studies show that 90 to 95% of people get relief within 6 months. 6 months sounds like a long time, but it's better than having surgery. So really we push conservative treatment of this, and I would tell you that anyone telling you differently would be not doing you, they would be doing you a disservice, because really this is a large majority of the time something that will go away with different things you can do. We'll go over those in the next slide. You really reserve operative treatment for at least 12 months. If you really don't have 12 months, it's just probably, you'd hate to trade, the pain in your heel for a painful scar, So conservative care, physical therapy, and honestly, physical therapy is nice because they can do some other things like arthrodesis, which is kind of like giving you a topical medication. They can do ultrasound techniques that can sometimes help it feel better. But probably the best thing to do is stretching. So stretching this about 10 times a day for about a minute each time is probably the best thing you can do for it. And then orthotics, kind of plus or minus in terms of how well these help. I do think these heel pads, a lot of people have gotten some good relief out of those. Icing is a great thing to do, and I've had some really positive feedback from that. So taking a water bottle, put it in the freezer, let it turn frozen, and then once you put it on the floor, it's sort of like stretching and icing at the same time. And I got really positive feedback about that. You may want to hold off on activities for a couple of weeks just to see if you can get it to calm down from that standpoint. Sort of that 6 month marker is sort of the, most of them go away within 6 months. So after 6 months, you start talking other things you can do. Shockwave therapy is something that's out there. It's sort of like a high-powered ultrasound. We don't have access to this in our group currently, but we're working on it. But there are some good studies that show that they did a randomized control trial. I mean, they blinded people. They made them not know which kind of treatment they were getting, and then they checked them at intervals up to a year afterwards, and they actually had a good, better improvement in terms of symptoms with doing this. And so what it does is sort of like a high-powered ultrasound. It kind of stimulates angiogenesis. That means kind of new blood flow to the area to help it heal. So that's something. Insurances are a little bit plus minus in terms of covering that. So that's why we usually also reserve that for later on. And the same thing is true for PRP, which is called platelet-rich plasma. What you do there is you take off blood, your own blood, you spin it down, and you take the anti-inflammatory properties of it, and then you inject it back in. That's also something that insurance doesn't necessarily pay for. It is something short of surgery you can do, but the success rate on that is a little bit mixed too. You kind of get studies that go back and forth on that too. So just to let you know, there are some things out there. Another thing is steroid injections. Those are good. They can be painful, but they do really help in terms of decreasing that pain. The downside to them is you can actually rupture your plantar fascia, which would be pretty painful. Peyton Manning was probably the most recent person that had a partial plantar fascia rupture, and that was the thing that kind of kept him out mid-season this year. So they can certainly limit your activities. So you wouldn't want to have that. Now, truth be told, when we do the surgery, we're actually cutting the plantar fascia, so we're releasing it. So in that respect, some people can actually rupture it. In fact, if they rupture it completely, they almost get pain relief because it doesn't exist anymore. It's sort of like having a surgery without making an incision. So casting and a boot are other options. Typically, try not to do that if you can. So this is the stretch. So the best thing to do here is if you can take your ankle and place it on your heel. So imagine this kind of resting here. You can take one hand, and you really want to bend your ankle up, actually even a little bit more than this, and bend your toe back. What this does, it places the plantar fascia on stretch, and also it stretches the Achilles tendon, and then you use your finger to kind of push along where that plantar fascia is. And that's the best stretch to do, and this has a very good chance of getting you better. Now these frozen water bottles, golf ball, you hear about people doing those, can be helpful, stretching your Achilles tendon. These are the heel cups that we have in our clinic that we use. That especially if you're up on your feet a good bit, these can be helpful just in terms of taking pressure off of it. There are some night splints that you can wear. So, the theory is you sleep with your kind of foot down all through the night, and when you put your foot down on the ground when you get up in the morning, it sort of stretches everything all at once. So the thought is you keep someone kind of stretched out through the night, and that may decrease his chance of having it in the future. And in all honesty, I think people kind of have a pretty tough time wearing these, especially if you get up in the middle of the night and you go to the bathroom. It can be somewhat problematic, but it certainly is an option. And this is that the high-powered ultrasound with the shockwave machine here, and that's an example of the platelet-rich plasma injection or cortisone injection. That's kind of how it's given. So we kind of talked about icing, heel cord stretching, orthotics and anti-inflammatories. Those are the mainstay of treatment. And really, that's what you'll hear from us. And actually, the Foot and Ankle Society and Consumer Reports just recently came out with a little handout that we can figure out a way to set those up to get you a link to them. But if you just Google Consumer Reports and Foot and Ankle Society, they have a one-sheet handout that kind of summarizes a lot of things that I talked about here. Just because I think Consumer Reports is aware that it's one of the most common things that we see, and I think it's helpful to give patients information on that. So these are a few studies looking at the platelet-rich plasma, which you talked about. Some people think that the way you actually do the spin down affects how good it works, and that's why there's the debate in terms of how effective that is. But in general, I think you wait on that. So the operative treatment, you really should give it 12 months. Sometimes we'll get an MRI to look for, if there's a nerve that's getting compressed. Also, a nerve conduction study can also help with that. Injections can help us make sure you're in the right area. And then after that, you can actually release it. There's a few different ways to release it. You can actually do it open, make a little incision about like this, kind of on the side, kind of curving around the bottom of the foot. You try to stay off the bottom of the foot if you can. To release it that way, and actually in training I also did endoscopic, which is you kind of make two little tunnels, just little small poke holes, and then you release it from underneath, just a little smaller incision. And sometimes these people with high heel cords, we also have to kind of release their calf muscle too. That's what that is. So, but overall, a pretty good success rate with this surgery, but it is one that you just gotta hang in there. So this is the endoscopic, when we make kind of two poke holes on either side, and you use the knife to kind of release it underneath. And then you have a camera on the other side kind of visualizing that. So this is kind of a smaller incision technique. And then if you do an open approach, you'll make an incision about like this on the side of the foot. Where afterwards, we usually keep you in a splint or a boot for about 2 to 3 weeks, just make sure the skin heals up okay. Then we remove the stitches and allow you to kind of do a little bit more walking and therapy at that point. So in terms of kind of getting back to normal shoe wear and walking around, for long periods of time, it's probably going to take about 6 weeks or so. Some people can have persistent pain in that area. If you release too much of the plantar fascia, there's some thought that you may kind of develop a flat foot because it is one of the things that kind of holds your arch up. So that's something that it could play into it. And then there's nerves in the area, so you could potentially irritate those. Infection is a complication, but overall, when you need it, it's a good surgery. So Achilles pain is also something that's fairly common in our practice. It's sort of the back of the heel pain rather than the bottom of the heel. And so the proper term is Achilles tendinopathy, but there's the 2 points where people get it are either where the tendon attaches to bone or a little bit higher up where it's just all tendon in that area. Because the blood flow isn't good in this area, that's a common place for it to happen. This is also where ruptures occur. You probably had some friends that ruptured their Achilles tendon, or Kobe Bryant, for instance, was kind of one of the more common people that have been talked about with that. And then, but if you just have continued pain in that area, this is this. Haglund's deformity is sort of a pump bump. So if you look at the side of the foot here, some people have this like little area that's more prominent, almost kind of like a spur. And you can imagine if you bend your foot up, this will hit and irritate that tendon and cause that insertional Achilles tendonitis. So you get these bumps on the back of your heel, it's painful to touch, hurts in the morning when you put your foot down on the ground and go. You have to stretch this out. And that's pretty classic. It's very common in runners, especially those who are a little bit like myself, a little overweight. And but this is chronic heel pain is one of the most common things. A tight heel cord is gastrocnemius. That's what that means. Is tight heel cord. That's also common in this too. So you can get some swelling as well. So in terms of, you came to see me in clinic, the things we would get an X-ray first. Now what this does is it lets us know, if there's a bone spur there, that probably tells us you have a less likelihood of getting better with time, a little bit of a prognostic value to it. Also shows us if part of your Achilles tendon becomes calcified or almost turns to bone as it attaches, so that's important as well. Ultrasound can sometimes be helpful if there's you feel like there may be a tear or something like this. And an MRI, if you're just having a hard time defining exactly what's going on, or you want to know what percentage is involved of the tendon. So these are examples of some MRIs. So this is the insertional, or where the Achilles attaches to bone. It really attaches right through here. And you can see that's a tear right here. The Achilles tendon is a nice black structure right through here. And this is the ankle joint here. The toes are kind of over here. This is your heel. So this is the non-insertional. You can see that's where it attaches to bone. That looks nice and black and healthy. Right here it's starting to get gray and really thick. So that's the non-insertional category. So treatment options, luckily for both of these things, stretching exercises is the best thing you can do, believe it or not. Sometimes you can't go right away to therapy. The pain is just too bad. So we put you in a boot for a few weeks, potentially with a heel lift, just to let it calm down enough to where you can participate in therapy. Then once you get into therapy, this is the main stretch we want you to do. So it's called eccentric stretching. So that means you're lengthening the muscle and tendon as you stretch it. So for example, the most common thing is to say you go up to a stair, go up on your tiptoes, and then try to slowly go down to where your heels go past your toes. So you're kind of firing the muscle as you stretch it. And that's the best stretch to do. And that has a very good effective rate. 50% is probably a little on the low side. Probably studies show about 60 to 70% will get better without surgery with this. Anti-inflammatories are helpful. Again, these shockwave and platelet-rich plasma, they cost money, and it's typically not covered by insurance, so we typically don't offer those. But heel lifts are helpful. Night splints, like the plantar fascia splints, is a similar deal. So operative treatment, you really give it about 3 to 6 months to make sure that this doesn't isn't something that gets better for you. But if it's not improving, then you go for taking it to surgery and get you good. This is a good picture in terms of how to do the stretch. The important thing to know is that so the Achilles tendon that's right here, it attaches to 2 muscles in your calf, the gastroc and the soleus. The gastroc actually attaches to the bone above the knee joint. So that's important when you do stretching because you want to keep your knee straight, because this puts more stretch on the gastroc as well. So you're stretching both the muscles in this area. So if you see here, you kind of see the knee has been over here. See how much further the ankle goes up, and it doesn't go up as much over here. That's why, because you're really focusing on the gastroc too, which is a big proponent of a lot of things.
So do you do both stretches?
No, you just want to do it this way.
This is
That's right. This is the right way. This is the wrong way.
Okay.
So you want to keep your knee straight, not bent, because you'll be able to. The fact that you can't get your foot up over here is better, because you'll be able to stretch what you need to stretch. So doing it with your knee straight, you're really stretching the gastroc, which is great. And then, so we talked about non-operative treatment. I'd like to show you, I have a picture here of the. So this is sort of the repair that we do. We actually take that bone off, and then we split the tendon down the middle, take out the bad portions of the tendon, so that the painful portion of it, remove all those spurs, and then reattach it down to bone. We have these little anchors here that have these. It's like a really thick suture, and that can help to reattach that back down to bone with no significant knots or anything like that, and really suck it down. And this is a very good surgery in terms of getting rid of your pain. Once you've exhausted all of the non-surgical options, it has about a 95% success rate. So just in terms of showing you what it looks like beforehand, you kind of see here they have a pretty big prominence here. They don't have a big spur back here. And then, so you take that off, and then you have these anchors in there to kind of reattach it back down the bone. And so it's a very reproducible surgery. The only downside about it is we go back to the, let's see, I got it back to here. I thought I had the post-operative protocol, but basically it's just a little bit longer recovery. You have to be off of it for about 6 weeks, and then you start putting partial weight on it after that. So while it is a good surgery, it does require recovery, and before you're up walking around on a regular basis for a long period of time, you're looking at about 3 months. So just in terms of taking time off for surgery, recovering, that's kind of what you're looking at. But it's a very effective surgery. There are some complications with it. That area isn't great in terms of the skin, so we're very careful with it, and wound problems is the most common thing. It can be up to 11%, but and with diabetes, that does raise your risk for infection. But overall, it's very helpful, and luckily with this, it's been a little bit less in our hands. And then in terms of blood clots too, we always put you on a blood thinner afterwards. If you haven't had any blood issues, usually just an aspirin a day. So bunions, another common topic here. So why do they happen? So the causes are really multifactorial. You're either born with it, you can blame your mom. It's typically in women. Many times it's hereditary. Another interesting thing is high heels will actually put a little more pressure on your forefoot and can kind of narrow. They usually have narrow toe boxes or the space for the toes. That also causes an increased risk. There's actually one study in China before they had introduced high heels. They looked at everybody's feet, and then high heels were introduced, and the rate of bunions went up about 80% with the introduction of with high heels. So there's definitely something to that. It can be related to like rheumatoid arthritis or gout, or it can play a part in this. And then we talked about shoe wear, and then high heel cords also. But basically, if you're looking at what is a bunion? So basically, it's where your toe starts to deviate towards your lesser toes. Your big toe starts to come over like this. And so, a lot of people, it starts kind of back here even. So this is kind of your midfoot right in here. This is kind of the ball of your foot right here. So sometimes this bone will kind of come over in this direction, and then the toe starts to veer off in that direction. So sometimes we'll actually have to come back up here to fix this. And so we'll go into more in depth here. So common symptoms, it's usually either pain over the bump, or it can even develop into arthritis, and you have pain with any type of motion to your toe. You can start to get to where your toe comes over so far, the second and third toes are sort of the longer ones in terms of when you walk, and you start to get irritation. You get your second toe kind of become a hammer toe and pop up over your bunion, things like this. So one way we've got to grade this is you look at these are kind of like the kneecaps for the big toe. They ride on the bottom surface of the toe. They're called sesamoids. And it's sort of, depending on how far over these are, that's sort of one way to measure the severity of a bunion. But these are normal. You can kind of see them right here. So these are supposed to sit kind of right in here and right in here, but you can see that they're shifted over a pretty good bit, almost all the way out from underneath the head. And what those attach to, so like the kneecap, it's attached to the quad tendon and patella tendon. So that those kind of help the knee track. Now, with these, the toes that flex the big toe, that's what they're attached to. So you can imagine as it kind of comes over more, it's sort of like a pull that kind of pulls the toe more into a bunion too. So there are some adolescents that have bunions, and typically those are very much hereditary. And sometimes we have to treat those surgically. We try to wait until their growth plates are fused, so that's not an ordeal. But sometimes their deformities can be just as severe as some of the elderly ladies that have a crossover toe, or second toe that kind of comes over the first. So you try conservative treatment, especially in those young guys, as much as you can, but sometimes you need surgery. But for the most part, there's a lot of different procedures. If you look across for all different orthopedists and podiatrists, there's many ways to fix a bunion. And there's probably no perfect way to just do it that way every time. They all have their risks and benefits, and you sort of have to take a look at the global picture and what you have going on and make your decision based off that. So you try conservative treatment whenever you can, because anytime you touch the big toe, you always worry about stiffness. So that's always a thing you have to mention. It's the most common thing. It happens 10 to 15% of the time you get that big toe stiffer. Doesn't always necessarily mean it's going to be something bad. It typically will stiffen the toe. So trying these little toe spacers are helpful. If you're walking in a shoe, if you have a toe box or area for the toes, it's big enough to accommodate all the toes, that's helpful. And sometimes this toe spacer can make the bump over here not quite as big, and that can help. There are these bunion splints, plus or minus in terms of how helpful they are. You can certainly try them. There's no downside to them. Sometimes, though, they have a strap that runs right along the bunion, and that sort of almost defeats the purpose. It's a difficult area to kind of brace or splint. But these are sort of the procedures that we talked about. I'll kind of go into depth a little bit. But basically, you don't want to do it for cosmetic reasons. It's just, there's too many risks involved to just do it just for looking good. But if you have pain there, it's certainly worthwhile. And if you want to get into a regular shoe, and walk around without pain, or at least much decreased pain, this is a great thing to have done. You can try orthotics. I think people with flat feet, as they kind of arch falls more and more, you can get a little bit more prominent bunion with that. So I do think orthotics can be helpful in that way. And we have Heather Stacy that works with us pretty closely and does a very good job in terms of our orthotics.
Do you know if the orthotics are covered by Medicare?
That's good. For diabetic patients, they are. Let's see, Advanced Orthotics, I believe, does that through insurance. Yeah, through Franklin.
Okay.
I'm pretty sure. We can double. We do. We will figure that out for you if you come see us in clinic. But typically they are covered. The diabetic shoes.
And I think my understanding is it's like one pair of shoes a year or something.
Yeah, it's
like
either
that.
one every year or every couple of years.
Okay.
I don't know the hard.
Or maybe it's the insoles. I don't know.
I think it's shoes too.
Yeah. But I was
Has the
thinking
rules
maybe.
changed? Because 2 years ago, I tried to get some diabetic shoes, and they sent me someplace over here off of right across from y'all's office.
That must have been a
They
mess.
said they don't do it anymore. They don't have a catalog.
So there's another group we have. I can't think of the name of it, but I think they did stop doing that a couple years ago. Insurance still pays for it, just that company has elected not to do that. So I think Hanger will do that. Orthopedics.
You're right.
So I think that's who we send them to now.
What's the name of it?
Hanger, like a clothes hanger. Hanger Orthotics. I know there's one in Spring Hill. I'm pretty sure there's an office around Franklin somewhere, but I'll have to double check.
I think they have an office also. If it's the one that I tried to call in Nashville, close to between Centennial and what I call Lapidus, St. Thomas Midtown.
Yeah, that's right. That is.
But I don't know if they have a location here in Franklin.
I don't think they do. I don't know of anyone in Franklin doing them then, if they're not, because I think Heather
But
Stacy
Hanger
used
does
to
them
be.
for sure.
Yeah, for sure. Absolutely. So at least there is an option for you. Hopefully it's just a yearly thing.
Now, what might have happened to you is that a lot of the retail places don't want to deal with the insurance billing and Medicare billing. But it might have just, so what I'm saying is it might have been where you went to get your shoes. That they weren't
That is
covered
right.
there.
They used to do it up until about 2 years ago. Because
TLC used to do it, because I used to get mine there. And they
Okay.
quit doing it, it's through the catalog now.
Yeah. Which is,
Well, what I ran into is you had to get a prescription from the doctor,
yeah,
and then you go buy your shoes, and you turn the prescription and the receipt into Medicare,
right.
and hopefully they reimburse you.
I don't know the ins and outs of that one specifically, but you're probably right. But I do think at least Hanger will work with you on that and help to get it done. That's pretty much orthotics. You know, once you've tried, you know, orthotics or splinting or adjusting your shoe wear to give you room, if it's just too prominent, you know, if it's just bothering you, then you start looking at surgery. There's a couple different options, and it depends on how severe your bunion is, to what you need. So you really give it at least 3 months of trying to do certain things, and then mainly all bunions get some form of this, where you just shave the little, it's called the medial eminence, or the sort of inside part of the bunion off. You shave off a portion of the bump. Nearly just about anything you do, that's true. And so this is sort of a portion of the procedure. We call this one a bow, but it's not too different than like what we call a chevron osteotomy if you're in the kind of woodwork. I do mine just slightly similar to this one here. So this is a type of osteotomy or a way to cut the bone that has a stable, this is actually borrowing from woodworking here. So so you kind of use their stable osteotomy to what they would cut wood like, use it as a stable function. That's what we do. And so in terms of this procedure, if your bunion isn't so significant, you can actually shift this bone over and we can begin weight bearing within the first couple of weeks. Now you walk more on your heel at that point and on the side of your foot because A, it's painful, and B, you have surgery there and you kind of want to protect it a little bit, but it is stable enough to put weight on. And this is an effective surgery for kind of, if your bunion isn't so severe, and there's some angles we look at and kind of judging that. And so this has a good success rate, pretty low complication rate, a slight chance of it maybe drifting back slightly. But this is a pretty solid track record, especially for those kind of moderate sized bunions. So another lunchtime picture here. So this is the second type of surgery we do. We actually are looking at so this is I think this picture's got switched, sorry about that. So this is the kind of osteotomy we do here, and then we're marking it out beforehand. And this is the bunion before surgery, and this is after we've kind of shifted it over. So now we're looking at those sesamoids and how they look, and they're kind of right back underneath, and the toe is straight. You kind of make a little bow to the bone here, but for smaller bunions such as this, that's acceptable. So if you looked at the foot here, you'd see a pretty straight toe. Now, so this is kind of an example of that. So that's before up here. Those are the kind of incisions that we've had right through here. And so this is how it looks afterwards. So it's before and after, and pretty nice before and after. So if you have a bigger bunion, we talked about, sometimes you have to go to the midfoot to look where the bunion starts. Some people have a really loose joint in that area. And this is typically those adolescents or people that have a flat foot. Those are the people that typically have this. And once it gets wide like that, there's a doctor named Dr. Lapidus from New York that described this. And basically what we do here for these large ones is, if you look, the two bones right through here, the second metatarsal and the first, this one starts to veer out and go wide. And so starting from this joint here, so we kind of make a little cut here to get these two bones to heal back. And there's only about 10 degrees of motion at most in through here. So losing that amount of motion doesn't necessarily affect you very much. And it really doesn't. And then so this gets this back straight, and then we loosen the capsule over here, tighten the capsule over here. Sometimes we'll take a little wedge of bone out here. This is for the more severe bunions. It has a better chance of preventing recurrence. So if you want your best bet of this never coming back and being a problem for you, that's the key. Sometimes we take a little bit of heel bone just to add it in to help it heal. The disadvantage of this is you have to be off of it for a total of 6 weeks completely, so not put weight on it. There are some things that we have now, like knee scooters, where you can put all your weight through your knee that helps in terms of doing this. but really it's about 2 weeks of kind of staying off of it in bed, keeping it elevated, let the swelling go down, and then you can start to be more mobile, getting around that way. Crutches or knee scooters is very helpful. And so these are some of the pictures here. You can see as it kind of gets further and further over, you start to get calluses underneath the second toe as well. So, this is back to the picture that I looked at before. So this is the joint here that we're fusing. So you kind of take that out and put screws across it. And then we do a release on between the first and second toe, because you can think about it, the capsule or the joint lining gets really tight on this side. So you have to loosen that out. And then we'll take just a little bit of bone, from the heel just to help it heal. And then that's how we get this straight. So it's kind of faded out here, but there are 2 screws that cross this joint to help get this to heal. And you can really see here, you see the angle that goes between here, you really correct that, and you get these sesamoids or the small bones back underneath the big toe, and that does a lot in terms of correction. And so these are some of the x-rays that you can see post-op. You just kind of tell by the soft tissue shadow that that's all good in there. So sometimes we'll need to take a little wedge of bone, like I was saying, and this is kind of what that looks like. So after you've done it, say it still has a little bit of a wedge to it, you can angle it a little bit as well. And that has just pretty minimal effect in terms of recovery. Say you have pretty significant arthritis or rheumatoid arthritis even, and it's just you have pain no matter which way your joint moves. That's an indication to get this thing to fuse. So especially if you don't have much motion there anyway, you're really not losing a whole lot. Now, so you think about fusion, it sounds like a negative term because it sounds like no motion. Well, you can actually still bend. So if this is your kind of big toe joint, you can still bend the end of your toe down. It can still go up and down. You can still even wear a little heel, like about a 1-inch heel, something like that. And you can walk around for even miles, and that's been shown to be able to get you reproducibly back to that kind of activity. So even though fusion has some sort of negative connotation, it's a good surgery, and people are very happy with them on the whole. So you want to do it for someone who's got severe changes or like rheumatoid arthritis is probably the most common people to get this. Sometimes, we talked about tight heel cords. Sometimes we have to lengthen those if they're too tight to take pressure off of the forefoot or the front of your foot or the ball of your foot. And so this is what this is. You make a little incision up by the calf. You lengthen that gastroc muscle, and that helps to kind of bring your foot up just a little bit more so you don't put as much pressure on your foot as you walk. So, basically we kind of talked about the two big, also when you do a fusion of the big toe joint, so that's not as long off your foot. You're off of that for about 2 weeks, and then you start putting full weight on it. So it's not as bad of a recovery. The Lapidus, the one where you fuse the bones in your midfoot, that's the one that you 6 weeks, but it has the lowest risk for recurrence. So complications, you can almost do too much to where it goes the other way. Luckily, this is pretty uncommon, called hallux varus. You can have the bunion come back. Luckily, that's also pretty uncommon, or if it does, it just drifts back a little bit. Stiffness is the biggest thing, and then, promising, if anybody promised you can get into high heels again, I think that's a little much to say. Luckily, I don't see many stilettos here today. Getting back to sports, it does show a pretty good return to getting back to high level of sport. So hallux rigidus, and what this is, it means it's a Latin term for stiff big toe joint, essentially. And so your big toe joint here, you saw those pictures in the last, and you can see there was a normal joint space on those, and here it's just almost obliterated, right? They don't have very much motion. And hallux rigidus is just sort of a spectrum of arthritis of the big toe joint. So as it gets worse and worse, your motion gets worse and worse. There are some people that just get pain as they walk when they roll through their gait. Their big toe comes up and they have a spur on top, and that just pinches at the top, and that's what causes their pain. There are some people that have just frank arthritis all through the joint, and that's a different category. So there's a little bit of inheritance to this. So you can blame mom and dad on this one as well. This was actually more common in males. And so, when you look at what's normal range of motion here, 90 degrees, kind of make a 90-degree angle at the ball of your foot is kind of what normal, it's what you're going for in terms of running or doing any high-level activity. And even walking around, you want as much motion as you can get out of that. So what arthrodesis is, you start to get a little wear at the top of the joint, and you can actually form a spur on top. So that spur can actually cause the impingement or pinching off that area. So you can also be painful with shoe wear. So these are some x-rays of some really good ones. I mean, this is like a free piece of bone that's just floating up there, and that big angry looking spur, and this is a similar thing here. So those are the enemy right now. Now you can put some things in your shoes. So if you put this is called a Morton's extension, and what this is just a harder piece of plastic. It goes into your shoe. It goes underneath your big toe joint. It makes your shoes stiffer underneath your big toe, so it decreases the amount of motion, and that can help with pain control. You can also do injections and anti-inflammatory medications, and after these fail, you consider surgeries. And so there's, again, kind of a little surgery and a bigger surgery. And for this one, you really want to wait, in terms of shoe wear and things like that. But once you get to surgical options, it depends on how much arthritis you have. So if you just have kind of, about half of your joint like this, but the bottom half of the cartilage, the cartilage is like the smooth surface. As long as you have some good cartilage on the bottom side, it's still okay to just shave the bump off. And that's actually can still leave you with motion, because what do we do during surgery is actually cut the bone. So, you see this spur here, we actually cut down into where the cartilage is and remove the bad area of cartilage. And so that allows, and sometimes we'll even take a little wedge of bone out of here, because you really don't have to go down that much with your toe unless you're like a ballet dancer trying to go on point. Most people are trying to go up with their toe, so you can borrow from down to give you a little more up. And so shaving the bump off is called a cotylectomy, that's our fancy term. But removing about 25-30% of the joint too, removing the area of arthritis, is also helpful. And then taking that little wedge of bone out is called a Moberg osteotomy. In this combination, even with decent amount of arthritis, as long as you don't have much pain within the mid-range of motion, you'll do okay. But if you have pain as your toe goes up, this is the surgery for you. Luckily, you can start putting weight on this immediately, and then I've even had a few patients back to running in 3 weeks, which is a little ahead of the game. I didn't ask for her to do that, but she certainly did well with it. And so this is kind of a picture of taking a little wedge of bone out. But this is some of the guys I trained with and had a pretty high satisfaction rate with this, and only a few of them had to go back for surgery for a fusion of getting it to, it's the same surgery as what you do in a bunion that's severe. You fuse the joint. So this is kind of an example of the schematic there. And these are some pre-op and post-op x-rays there. But the big deal is that you're getting your toe to be able to go back up a little more. This is kind of, once you even shave the bump off, you can still be stiff. And so this is after doing that little wedge of bones. It helps you get your toe up a little bit more. So say you come in with this, that's just beyond what just shaving the bump can do. That joint's completely obliterated, and so this is one where you consider fusing. Now in this one, this bone's also a little long here, so she had some pain underneath her second, the ball of her foot underneath her second toe, and so we had to shorten this one as well. And so this is kind of what that looks like. So you get this nice and closed down with a plate on top, and that has a good track record of healing. About 85% or more in terms of getting it to fuse, and even half those patients that don't fuse actually don't necessarily have pain, even if it didn't heal back right, so you just leave those alone. So a good track record of getting you better. You can still wear an inch or two in terms of heal, and most people are pretty satisfied with this as well. So these are kind of some pictures of different plates, I guess. But overall, you know, you get that good bridging bone along there. That's the goal.
If you remove arthritis, does arthritis come back?
Once you get the joint to fuse, that eliminates arthritis. That's how you take care of arthritis. So it doesn't. It doesn't go back. That eliminates it, and then that's why you know if you come in and you're asking for one surgery to be it and done with, that's the go-to, because that basically eliminates it. Now there are some replacements that people have talked about in that joint. Say if you can actually do replacements or even a partial replacement, and the problem with this is the current studies have shown a failure rate of almost 50%. So we don't recommend that at this time from my standpoint, because they have just too high of a complication rate. But those things are out there, and people in the area do them. But overall, you know, if you have to do either one of these, people are pretty happy with both of those procedures, and even pretty functional long term. Any questions about anything?
The things on your screen, is that mostly for older people? Younger people are not bothered by?
Which one? This.
Well, the plantar thing.
Plantar fasciitis?
One of the things said adolescents.
Yeah, that was bunions. So there's a certain category of bunions that come about in even teenagers. Like I have a young boy in my clinic who came in with a pretty significant bunion, just because that's kind of the genes he was born with. So they can happen in all ages. Really, all of these conditions pretty much happen in all age groups. You know, bunions are more common. The arthritis things are more common later on, but they all kind of, you know, plantar fasciitis knows no age. So for all ages. Yeah, so we have our cards over here, and this, you know, I told you we were opening up the new foot and ankle clinic, so that phone number will do scheduling for that clinic. I don't know if anybody, you know, so for those of you in Franklin, that's a great location. It's right by the old Vanderbilt, you know, Franklin Bone and Joint / Vanderbilt Bone and Joint Clinic on Bedford Way off Royal Oak. And then, so like I said, Dr. Dieter and Troner, the podiatrist, will be there, and so will Dr. Durr and I, so you could, it would not be hard to get in to come see us. The other thing is we do have a couple other satellite clinics that are opening up as well. So for Spring Hill, we have a location on Port Royal and Saturn Parkway at the Vanderbilt Regional Building, and then also we're opening up an Brentwood office as well coming in the next month or so, kind of right across from where the Kroger is on Franklin Road. And,
is there any exercise that will kind of be a catch-all to present some? I know you mentioned the rolling your toe for the plantar, but what about the other stuff?
I would say heel cord stretching is probably the best thing you can do. And if you can't do the stairs where you can kind of go up on your toes and go down, even just coming up to a wall and kind of putting your hands and bracing yourself and putting one leg back and kind of lean into it. That's stretching your heel cord is, I think, just a good daily hygiene thing.
I was wondering if that would be where you went if you had neuropathy and you had swelling of your legs and your feet, or is that a different doctor?
Are you having pain with it?
It's tingling and
Okay.
Cold.
There's not a lot that we can do in terms of, you know, so that's more like a nerve issue. And I think Dr. Lonergan in Cool Springs does a lot with help with those things in terms of there are some medications you can get. You may have heard of Lyrica and Neuron. They can help with that nerve type pain. And so either your primary care doctor or one of the pain management doctors are probably better to go to for that specific pain.
Well, after going to them, and then there's nothing they can do, then I didn't know what doctor you went to. Excuse me.
Have you been to a neurologist?
Well, I went to a neurologist for my back and did surgery, and it didn't work. and that's because my leg was going numb and all that, and my back hurting. And so now that I've got all this leg and foot trouble, and I don't know if it's related to the back or
The back
what's going
or-
on. I can't figure it out. I take Lyrica, it's not doing any good.
Okay.
So,
Yeah, it's, we do have a couple of spine guys in our practice, Dr. Cleacamp and Dr. McNamara, who may be able to help sort those things out. You know, if you're trying to figure out, is it coming from, because I mean, if you have diabetes, you're trying to figure out, is it coming from the back or is it from the diabetes, because you get neuropathy that way. So I think as long as you just make sure that it's not coming from the back, you then get probably pain management and your primary care doctor are probably the two best people to go to just in terms of managing that, just because there's
so
not a lot.
Dr. McNamara at the bone and joint is that kind of doctor?
He does, Dr. Cleacamp and Dr. McNamara are both our spine surgeons.
Thank you.
No problem. Any other questions? All right, thank you very much for your time.
Thank you so much for coming.